So before we go on to the next speaker, I want to really quickly hand it off to Brian. We would really appreciate it if you guys could fill out this quick poll.
Hi, sorry, I'm having some video issues right now, so you guys won't be able to see me, but I'm just going to run a quick poll right now just to kind of see how everyone's doing with the different topics and how they're feeling about global health. So I'll launch it right now. Okay, perfect. Thank you so much, everyone, for everyone who's participating filled out this poll. I will keep it up for a little bit and then we'll end it shortly, just to give some other people some time to finish it. But I'll pass it off to you, Mayor.
Okay, so I would like to pass it on to Annika to introduce our next speaker, Dr. Bly.
I'm delighted to introduce one of my mentors next. Dr. Bly is our speaker. Dr. Bly is a pediatric otolaryngologist at Seattle Children's Hospital and also holds a faculty position at the University of Washington. Prior to attending medical school, Dr. Bly obtained a bachelor's degree in mechanical engineering. He now actively incorporates engineering applications in his practice to help address accessibility in healthcare.
There we go. Hi, everybody. Randy Bly. Thank you for that kind introduction, and thank you to all the organizers. Are you guys hearing me okay? Can you thumbs up or something? Okay. Well, I'm really excited to be here. You guys have done a great job, and I really enjoyed Dr. Lutz. Your presentation was great, and there's a lot of synergy, and I think we should meet up, actually. And, you know, one of the, and so I'm going to share my slides here, and we'll go right into it. And okay, so does that look like a reasonable view? I don't, okay, great. So Annika very kindly asked me to talk about mobile health technology. And, you know, I'm a head and neck surgeon, and I do pediatric head and neck surgery. As Annika mentioned, my background is in mechanical engineering, and you know, I know you guys are going to have a presentation later on different paths to medical school. And also I would add to that very different paths in which you can interface with medicine and global health, as Dr. Lutz just showed really awesome examples of doing that. And you don't need to be a practicing physician. And a lot of people would argue that if you're a practicing physician, then you're just going to be doing that, and it's harder to have time to do other things. I'm in a spot now where I'm kind of trying to do a little bit of both, of conducting research that has applicability in global health and in diagnostics. And it was a great question about non-infectious diagnostics to Dr. Lutz. And some of the things I'm going to be talking about are using less biochemistry and more about mechanics to make diagnoses. And but that's one of the really fun things about this, is like everything's on the table. And it's about coming up with clever solutions and leveraging technology that's already there and inexpensive to do what we want to do. And so for the first part of my talk, I'm going to go through kind of how I've fostered these multidisciplinary collaborations, because that's really what's enabled many of these other things downstream to take off. For those who don't know, otolaryngology, as Annika mentioned, that's pediatric head and neck surgery. So we see patients with ear problems, we see patients with breathing problems, and there's a fellowship and a subspecialty just for pediatric otolaryngology, which is what I do. So my clinical practice is at Seattle Children's, and I do a lot of research interfacing with the UW team. Here's my disclosures. So I was first going to talk a little bit about my experience and background. Engineering and medicine has always been interesting to me. So my path was, when I was in high school, I was very excited about engineering. I actually came from a family of engineers, and nobody in my family had gone into medicine. And so I pursued mechanical engineering in undergrad. And then after one summer, I did research. I grew up in Ohio, and I did research at the Cleveland Clinic, and I was working with a group doing biomechanics. And I was recruiting patient subjects to come in, and we were doing gait analysis, or analyzing how they're walking. And I got really excited about that interaction working with the research subjects. And it wasn't until junior year that I was excited about going into medical school. And then I actually had to rethink. It turns out most of the engineering classes covers you pretty well for your pre-med requisites, but you need to add some organic chemistry and things like that unless you're a chemical engineer. So I did that over the summer, and then I did a year of research and did all the med school stuff along with that, and then applied to med school after that, and did that in Chicago. And then throughout medical school, you learn about all these great specialties, and that's when I learned about head and neck surgery, and how you wouldn't think how intricate and complex hearing is, and our hearing mechanisms in our body and the physiology with that, how much of it actually comes down to mechanics. And I'll talk a little bit about that today. And one of the goals, common themes, again, I don't consider myself an expert on global health, but what I've done is tried to create technology working with others that are very applicable to that. And one of the common themes that comes down to is making complex technology available for many in a portable accessibility, increased accessibility and accuracy. So I'll talk about a few examples of how we're doing that with smartphone-based technology for acoustic reflectometry, tympanometry, and otoacoustic emissions. Now, again, before I go into those things, I want to talk about how I started working with a group of engineers and how we basically have regular meetings. And as I mentioned, there can sometimes be challenges in communication. You know, surgeons have their stereotype for a reason, right? A lot of them are basically like stuck in their ways, and they were trained to do something for a really long time. And there's also this notion that, you know, if as a surgeon I change what I do, then there's a little bit of an acceptance that what I'm doing currently isn't perfect, because they want to offer the best things for patients. And engineers don't think like that, right? They're always thinking about ways to improve things and ways to make things more simple, more elegant, and take advantage of different opportunities. So I think one thing that I've observed is having my background in engineering, and again, I think just an undergraduate degree in engineering compared with the PhD engineers with whom I work is really nothing, except it allows me to communicate, because I can speak their language. And often what I'll be doing is kind of interpreting a statement that a surgeon says to an engineer and vice versa, to kind of break it down and get over some of those communications and barriers. Now, one like very practical barrier has just been regular meetings. How do we get everyone to show up at the same time? Because surgeons, please show up at 11 a.m. for our lab meeting. Like, that doesn't usually work. They're in clinic or in the operating room. And so one thing that we've done is we basically carved out time, and it takes a long time to do that. And then people can adjust their clinic schedules as they come. But that was a big challenge to begin with, is just how do we get everyone to show up? Because the surgeons want to meet at 6:30 in the morning, and there's not a lot of engineers that want to show up at that time. So again, for the next maybe 5-10 minutes, I'm going to talk about what we study at these engineering meetings, where we really like to look, we're looking at the science of surgery, and we're creating objective metrics to how surgeons can plan, guide, and analyze surgery. And then I'm going to shift into how we've developed some technologies that are smartphone based for this. Now, again, to kind of, one of the challenges we have is we have patients like this. Now, this is a CT and this is an MRI. And you guys, are you seeing my cursor, Annika? That's working? Okay, very good, thank you. And so this is called a meningoencephalocele, and this is basically a herniation of the brain where it shouldn't be. This is a big problem, causes CSF leak, meningitis, can be life-threatening. And so we got to think about how we can repair this. And so one, surgeons may say, well, we'll just go in through this way. And they basically, for lack of a better word, many times you're just kind of eyeballing the CT scan and you're scrolling through these 2D images. So one of the things, and this is how we're operating, is we have these endoscopes through long, slender portals to access regions. And here's that meningoencephalocele from the inside, looking at an endoscope through the nose. And so we started out by creating and basically quantifying a lot of the different surgical approaches we have. And this is just a skull showing all the different surgical approaches that are described in the literature. And, for any given lesion, sometimes you have to work around critical structures. So your endoscope has to go through here and work around structures in order to get to the target. And it used to be before endoscopes and a lot of technology, we would just do a craniotomy and you would open the bone here and you have full access. But that comes with a lot of morbidity and complications. So as we're creating these pathways to get to the target location endoscopically through a variety of different portals, it's easier for the patient, more complex for the surgeon. So we wanted to quantify this and figure out what's the best way to get there for a given lesion. So we've done a number of analyses where we're trying to get to these tough to reach spots at the interface between the brain and the back of the nose. And so we just like an engineer would say, well, let's do some analyses here. Let's look at what the range of angles are. And so we would do that. And then when we think about designing a new surgical approach, we have this surgical corridor through which we're operating. And here's we're describing a new surgical approach where we're actually going right alongside the eye, and that's okay. We can do that and we can get to back here. And so we're defining the 3D shape of this thing, just like a CAD drawing. We're creating, we're describing how we're going. But it turns out that when we really analyze it like this, we don't need that full thing. We can actually really narrow up the central part. And it turns out that reduces the volume of the pathway without impacting our ability to move our instruments at the target location. And so we can actually do some iterative design improvements on our surgical pathway. And it turns out that this part's really critical because this is the part, that's the size of the bony window that needs to be open in the back of the eye in order to get to this region at the skull base. So these little design factors are really important, have clinical importance. And we can of course come up with all sorts of metrics. And it's always key to point that back to, what numbers matter from a clinical standpoint? Where are the complications potentially coming from? And we can 3D print these, we can put our endoscope in here, we can put our instruments so we can make sure that we're able to carry out the surgical tasks we want to do through these dimensions. We developed this is a surgical pathway protector. So now that we know our dimensions of where we're going, we can actually put that thing in and it'll protect all of the structures on the side of the nose, along the side of the eye, as the instruments pass through multiple times throughout a surgery to get to the target location. And this thing is actually FDA cleared, and this is a success story for us. Now I talked earlier about making complex information available to others. So this isn't global health per se. However, you have patients all over the world who come in with complex tumors, and we need to figure out what's the best way to access that lesion. And so if you so the next level of analyzing all of these different approaches, hey, which surgical approach is best for this lesion in this patient with their specific anatomy? We're creating an algorithm that will derive that computation. And what we do for that is every voxel, this is oversized voxel here, but the voxels are, think of that like for you engineers, think of that as like the finite element in your finite element analysis. It's the smallest volume on the imaging study. And we can assign a value to that in the same way that, like, think about like Redfin or Zillow for your skull, right? You're like, where are the high and low value real estate, right? And we use that analogy because certain nerves are very critical. And if you traverse a nerve, then that would cause significant problems. Whereas other places, for example, in the air spaces in the back of the nose, traversing through there with an instrument is no problem and incurs no morbidity or problem with the patient. So basically, when we assign values to the whole structure, we can run an algorithm and do a cost optimization. And now our computer algorithm is actually outputting suggested surgical portals. And the reason why, and so this is just some snapshots of the program we developed to access these tough to reach lesions. And we of course give the algorithm a number of constraints about what the minimum size requirement is of the portal, et cetera. But the fact that we can enter in a patient scan to tell it where the lesion is and basically say go, and then it tells you, it suggests, right? And the surgeons can ultimately get to decide. So to me, this is a great example of democratizing complex knowledge. So, and I think of it as, like there are a number of really, really well-known surgeons particularly in skull-based surgery. And it's like, well, what would Dr. So-and-so do? And we can fine tune the algorithm to match that. So now if you have a patient anywhere in the world, you can upload the scan, tell it where the lesion is, and you could get an answer that's algorithmic based that says this is likely what Dr. So-and-so would do with X% confidence as we build more and more data in this. So this is a way to basically get almost a consult. Now, of course, you got to take into account clinical factors and whatnot, but it's a way of spreading expertise that goes into all this. So, and by the way, Annika, just raise your hand if there's any questions in the chat or something as we're going, and I'd be happy to stop and pause, because now we're going to shift gears and talk about a big problem of pediatric otitis. And this is a big problem because it is very, very common. Annika, go ahead.
Yeah, so one question that we had before we move on was many young people today are interested in multiple fields that may seem unrelated at first. A common theme we've seen today is interdisciplinary work. How do you envision the future of global health with the young people as interdisciplinary leaders, and what advice do you give to young people in this context?
Yeah, great question. I would say, at a stage of especially high school and college, I would recommend doing what you love at that time and getting excited about that. And I was very excited about mechanical engineering when I was in, I wanted to build robots and do all that. And I did that in college, and then things shifted. But I think there's a tendency to, especially in PhD or physician training, it's such a long haul. There's a tendency to always be like, oh, in 10 years, I want to be doing this. And you just got to grit through the next 5 years, and then it'll all be good. I would encourage you to do what you're passionate about now, and things will fall into place because you've seen Dr. Lutz's background. Things, you can't predict exactly where you're going to be. I think becoming an expert in something that you're excited about is most important, and then you'll find collaborators to fill in the pieces later. So if you want to go into medicine, maybe, but you're really excited about, I don't know, dance, or even something that's not science related, I want to encourage you to do that, because you'll never know when those two fields will overlap in the future, and how, and also, just from a med school application standpoint, they're interested in people who are passionate about things and who dive deep into things, and not necessarily just check all the boxes for those sort of things. Thank you for that question. So for pediatric otitis, so otitis is a fancy word for ear infection or ear inflammation or fluid behind the eardrum. It's super common. Many of you maybe had ear infections when you were younger, or younger folks who have had ear infections. This is one of the most common reasons why kids from like 12 months to age 5 years go to the doctor's office. 80% of all children at some point will have fluid behind the eardrum for about 2 months, and that can cause hearing loss. Sometimes it can be infected, sometimes not. The other thing is that when you have an 18-month-old who doesn't, articulate his or her needs perfectly, there's the symptoms may not predict the diagnosis. And so how do we make the diagnosis of acute otitis media? That's one of the challenges, because antibiotics are in the cards for treatment, but not always mandatory. But without a diagnosis, there could be a lapse in accuracy, and it's challenging. These are some photos of otoscopy. So we're looking down at ear canal. Here's an infected eardrum. You see it's bulging out at us. This one's clear, right? And it's red and inflamed. This is what an ear infection looks like when you look in the ear. This is, there's actually bubbles you can see. So there's fluid behind this eardrum. And this eardrum also has fluid behind it. And it's just a little harder to see. So it's challenging. The tools that we have to diagnose otitis are otoscopy, which is a fancy word for, looking in there. It's called an otoscope, this thing. Pneumatic otoscopy. This is not very commonly performed. Only less than 10% of primary care providers use pneumatic otoscopy, and this is a little bulb that you squeeze. This requires making a little air pressure seal in the ear canal and looking at the eardrum and squeezing and do a puff of air, and you see if the eardrum moves. If the eardrum moves, there's very unlikely to be fluid behind it. So that can improve accuracy, but it's not commonly used. Tympanometry and acoustic reflectometry. So these are getting into kind of mechanical tests that can quantify and objectively assess how the eardrum moves, which is one of the key hallmarks of an ear infection. There are other reasons why the eardrum might not move normally, but in a pediatric age group, with suspected otitis, that's one of the most common. And this is the thing that I'm fortunate to use every day. We have these in our clinic. This is almost like our stethoscope for my field of practice. Is we look with this is called an operating microscope, and we have binocular vision, and you can see right into the eardrum, and you can zoom in much higher than you can with this. This is the gold standard for me, but again, it's not very accessible. This is a great video from NIH. What's up? If you do NIH and how we hear, it's fascinating. And this gets into how, as complex as the hearing is, everything short of the cochlea is mechanics, right? So we have the ear out here that helps funnel the sound in, the ear canal here. This is the eardrum. And then if we move over here, here's the eardrum, and now it's zoomed in on the 3 little ear bones here. And the stapes is basically a piston that moves in and out, and it's amplified. So the sound comes in here and hits this drum, and there's a big area ratio here that amplifies the sound waves. And then the malleus and incus serve to amplify it from a lever effect. So as the stapes articulates in and out this way, it sends fluid waves in. And so all of this is mechanics, and we do surgery to rebuild these eardrums, and I do some research on that as well. So you kind of keep seeing how the mechanics sort into it. And again, if I had pursued a different degree, I'm sure I'd find different things that meet in with otolaryngology. So when we think about how to objectively assess the eardrum, there's a couple of ways to do that. And first, I'm going to talk about acoustic reflectometry, and then I'm going to talk about tympanometry. And they are similar, and they provide analogous information. And basically what we came up with, and this is working with my computer science collaborators, is that leveraging the nice microphone and speaker on a smartphone, we can make a little paper funnel here that will direct the sound directly in and to the ear canal. It doesn't need to go in very far. And we send a signal in, and then we basically listen for the bounce back. And we get a curve that looks like this. And it turns out that if you have fluid behind the eardrum, then it will look like the red curve. And if you have an eardrum that moves normally, it looks like the blue curve. And so we leverage this technology, and then we can do some statistical analysis that include a little bit of machine learning to help create this classifier. So now you can do this, very brief test that just plays a chirp in the ear. We have a DIY method of doing the paper funnel here, and it just tapes on. I mentioned that it's really hard to diagnose ear infections just in general. And I mentioned a couple of the ways that we have otoscopy and the microscope and stuff like that, but the real way to know for sure is to make an incision in the eardrum. And so we have patients who are undergoing ear tube surgery, which is a treatment for kids who get a lot of otitis. And so we designed this clinical study so we had a true gold standard. So these patients, and Annika was super helpful in this study, helped recruit a number of patients and families, and we would run the test right before they underwent anesthesia for ear tubes, and then we would make an incision in the eardrum, see what the fluid was, and then they would do the ear tube, place the ear tube as part of their routine clinical care, and this was just done in the background. And it turned out that we had we could very accurately use this device to tell if there's fluid. Here's our sensitivity and specificity, which you may say, well, that's not great, but that's way better than anything we have. And that's on par with conventional tympanometry. And when you look at the sensitivity and specificity of somebody looking in the ear with otoscopy, the data shows it's actually very, very, very low, almost to the point where it's a coin flip, which is one of the reasons that motivated us to do this. Here's just some more images of the data analysis that went into it. Again, we have a curve with fluid and a curve without fluid, and we're able to classify. We can do all sorts of sophisticated statistical analyses here to try to see like which parts of the frequency amplitude curve are most influential on classifying. And now, so this technology so as Dr. Lutz showed in a very nice slide there, that just coming up with the idea is like step one of 1,000, right? and for me, it's like it's the fun part, and it's what I want to keep doing, and like hopefully rely on others to kind of do a lot of the marketing and all the other stuff that needs to happen. And so for this device, we have a patent through UW, and it's been licensed to a startup company who is working towards FDA clearance, and we're excited about that. And Annika, I just want to do a time check. Do we have another 10 minutes? Is that accurate, or is it almost a few minutes?
You have 5 minutes now.
Okay, thank you. And so tympanometry is an analogous device as acoustic reflectometry, like I mentioned, but this is the one that's the clinical standard. Almost every audiologist uses tympanometry as part of routine hearing tests. The challenge with tympanometry is it requires, similar to that squeezing the bulb to do an air pressure test, this has a similar thing where it needs to create a seal, and it needs to actually move a syringe to send air pressure in there. And it does that coupled with a sound, and then it gives you the outcome of tympanometry. And here's so we created this box here that has all the inner workings to do that, where there's a little step motor that moves the syringe and sends that down a tubing. And then, so that information coupled with the sound energy allows you to create this tympanogram is what this is called. So this is a standard kind of readout that clinicians are used to looking at. And we designed a clinical study where we basically compared our smartphone device to the conventional device, The convention, one of the things that was really motivating us to do this is the conventional device is over $5,000. And we created this with parts that sum to less than $40. Now we've recently been talking to a lot of people about this. You do need almost an engineering degree, or at least some high level of interest to put all this together, but making it affordable, and we recently got this out there, and it's going to be, and it's completely open source, so any of you can look at this and look at the design. This is just some data from the clinical study showing all of our different tympanograms, and these are the ones for patients who have fluid. There's a type B tympanogram. If you have fluid, that means your eardrum doesn't move very well. So I want to allow some time for questions. So I think I'm just going to skip through these and just thank my many collaborators and our funding. And I'll pause there for questions. Thank you. And thank you guys again for inviting me.
So we do have a few questions for the audience. Louise, do you want to go ahead with those?
Actually, I have a question for the audience, from the audience as well. I think this question is more of a big picture question about your clinical experience with children who have hearing impairments. What have you experienced in terms of children learning how to communicate with the world after having hearing impairments? And specifically, what factors like neurological, physical, psychological adaptations do you have to overcome or incorporate to do that?
Yeah, great question. Obviously, hearing is critical to speech and language development. That's one of the things that we're always thinking about. And one common reason we see patients is for kids who are delayed in speech or have other things going on. It's delayed in speech development. And ensuring that their hearing is normal is a part of that workup. There's a wide range and different onset in which there's a wide range of hearing loss, and also a wide range of age at which it presents. Some patients are born without any access to sound, and they would potentially, they would go into our hearing loss clinic and would be eligible for rehabilitation either through amplification, and then some patients are eligible for cochlear implants. In terms of the type of hearing loss that's caused by fluid, that's relatively mild. That causes mild to moderate hearing loss, and the treatment is most commonly treating the fluid, removing the fluid either through a procedure or monitoring it, but amplification is also an option. And we talked about the mechanics of hearing. The different types of hearing amplification that are available are really fascinating. And there's, for example, something called a bone conduction hearing aid that will send the sound energy directly into the skull. And this can be done through a headband or through an implant that's implanted in the skull. And that can send sound directly into the cochlea, bypassing all of the things that I showed with the ear bones if there's problems there. So it's a long-winded answer, but there's a wide variety of how people present, and there's many treatment options available. And having access to sound is critical for speech and language development.
Thank you so much, Dr. Bly. I don't think we'll have time for any more questions, but thank you so much for the inspiring presentation. It was really informative, and thank you so much for your time today.
My pleasure. Thank you, guys.
Thank you.